talk through postpartum hemorrhage over the next 4 or 5 sessions. So what I've done is broken it up into small segments, and we're going to talk just quickly today about assessing the risk and looking at prevention of postpartum hemorrhage in those patients who are at higher risk. We will get into modalities of treatment and talk more about things that really particularly have to do with Dr. Gore's case in sessions to come as well. So several things we'll talk about today will certainly have implications. And really just to start out with a background about postpartum hemorrhage. And obstetric hemorrhage just in general is still the leading cause of an obstetric admission to the intensive care unit. That's important for us to know. We don't have a lot of ICU admissions in general, but this is a leading cause. Worldwide, it's responsible for 25% of all pregnancy-related deaths. Not so much here in the US, but definitely a major contender around the world. Hemorrhage that leads to transfusion is the leading cause of severe morbidity in the United States, followed by DIC. And the rate of postpartum hemorrhage, I think this is interesting. Its incidence has increased 26% from the 1990s to 2006. And the major contributor to that is an increased incidence of apnea. We'll touch on that a little bit later. But the good news is postpartum mortality has decreased from postpartum hemorrhage since 1990 in the United States, and it accounts for slightly less than 10% of maternal mortality in the US. And the reason for this is just what Dr. Gore showed in this case. We move more quickly to hysterectomy, and we move more quickly to transfusion therapy. We used to drag our feet giving people blood. We were scared of it, and we used to drag our feet with doing hysterectomies, and they have saved lives. Next slide. So just a little normal physiology. I'm not going to bore you with this because all of you know these things, but I just mention it because it's God's way of preparing the pregnant person for blood loss that is to come. And it really helps us in dealing with pregnant patients in that they have an increased red cell volume and plasma volume, cardiac output. And most of the coagulation factors are increased during pregnancy, or at least remain the same. So it helps diminish blood loss in the normal process of childbirth. Next slide. So the thing that you have to understand, and this case is a perfect example, understand that the patient looks pretty good with a heavy blood loss until they reach a certain tipping point. And young is nothing like being young and healthy when you have blood loss, because it helps us have that patient survive. But when the patient loses 10 to 20% of their volume, they really just have vasoconstriction, and a lot of times their vital signs don't look bad. But when they have over 20% loss, that's when you start to see the blood pressure fall, decreased cardiac output, increased tachycardia. And when it's over 25% loss, they fall off the edge of the cliff and have the cardiogenic shock, and it's hard to overcome. Next slide. So the key is to intervene early. This is just a graph with the red line showing how that vasoconstriction leads to the increased SVR, increased pulse rate at the same time. And then as the volume deficit increases, the blood pressure begins to fall along with the cardiac output. Next slide. So this is a slide from a textbook, and everybody knows it. I put it here just to help reiterate the stepwise fashion of progression of blood loss. And when you get over that 2000 cc blood loss, 30 to 35% volume loss, nobody's fooled by it. You know that they're going down the tube. They're tachypnic, they're tachycardic, they're restless. They are scary looking. And if you get to this patient when she starts to develop air hunger, you're in trouble. The key for us in obstetrics is to try to avoid getting to those symptoms of class 3 and class 4 hemorrhage and intervene more quickly. Next slide. So this is something that came out with ACOG's technical bulletin or practice bulletin back in 2017, where the real definition of postpartum hemorrhage changed. The diagnosis is made with a cumulative blood loss of 1,000 milliliters or more in the first 24 hours after delivery, vaginal or C-section. It used to be delineated 500 milliliters for a vaginal, 1,000 for C-section, but now it's clumped together. Now, it's important to note that if a patient has a vaginal delivery and she has an estimated blood loss of over 500 milliliters, that's not normal. And that is a red flag. And you watch that patient more carefully and closely and aggressively, but it literally does not meet the definition of postpartum hemorrhage yet. The other addition to the definition is or the blood loss associated with signs and symptoms of hypovolemia in the first 24 hours. And that really helps you include those patients who maybe started out with anemia and didn't lose as much, but they have definite signs of hypovolemia, or the patient that you don't know what their blood loss was, but they show signs of hypovolemia. You manage that and define it as postpartum hemorrhage. Next slide. We've already talked about this a little bit, and I think it can't be reiterated enough. The signs and symptoms often don't present until late, and once you've got hypotension and tachycardia, you've lost over 25% of their blood volume. So you just got to jump in and work fast to get these patients better. Next slide. So the sequelae, the ultimate sequelae is death, but you see all these things in the meantime. RDS, shock, DIC, acute renal failure is very common in these patients. You can see loss of fertility and Sheehan syndrome. Next slide. So we've already talked about these things, but just to talk about the increasing incidence of postpartum hemorrhage, I think it's an interesting thing to note. And it's really unclear exactly why we're seeing the increased incidence. We think it may have to do with the increased inductions of labor that we're seeing with the prolonged labors when we do induce patients. Advanced maternal age is a risk factor, and we're seeing more of that in multiple gestations. So a lot of the factors that increase the incidence of atony are believed to be the ground root cause of the increased risk or increased incidence of postpartum hemorrhage today. Next slide. So risk factors are on the right side of this slide. So if you look at the top risk factors, these are risk factors for atony, prolonged use of oxytocin. We just talked about that, high parity. I'll tell you, the one thing that scares me the most in patients, managing laboring patients, is choreo. I hate choreo. It can lead to the worst uterine atony that is not responsive to typical therapies. So I just warn everybody to be really careful with choreo. General anesthesia, there can be just small amounts of halogenated anesthesia given to patients, and it enhances blood loss. So always ask anesthesia if you've got somebody under general, if you have problems with bleeding, if they're giving any halogenated agents. Multiples, poly, anything that overdistends the uterus, anything that also inhibits the uterus contractile portion, like myomas, and abnormal implantation of the placenta. Operative delivery, precipitous deliveries increase the risk of trauma. And then patients, one of the reasons we look and mention on ultrasound if there's a subcenturiate lobe is to make sure you get all the placenta out when you do that delivery. I tell you, I just can't tell folks enough how important it is to make sure that uterus is empty I used to, in my previous residency program that I was teaching, and we had a high epidural rate, I would enhance the residents to sweep the uterus after every delivery because it was just such a commonplace problem at that institution. We don't seem to have it as much here, but don't forget it. The next slide, and obvious from Dr. Gore's case as well. And any evidence that the patient might have a coagulation problem, abnormal bruising, petechiae, anything that increases the risk of coagulopathy like abruption, fetal death, sepsis, all those things you need to be carefully attentive to. Next slide. So the World Health Organization and ACOG and the British College all have stated uterotonics should be given after all births. And that can be oxytocin. That's what we tend to use here in the United States mostly. It can be methergin. It can be misoprostol. You can do it any way you want it. Just develop your own protocol. There have been studies looking at what's better, Pitocin with meso or Pitocin without it. Pitocin with other agents, and there's really nothing seems to beat Pitocin, nothing seems to be superior to it, and that's just what we typically will use. IV is most often used, but you certainly can give it IM as well. Uterine massage, I still believe in. I think it does make a difference. The studies have been equivocal, but most studies do show a benefit in uterine massage. Just heightened awareness and aggressive management in these patients. And risk assessment, I don't think you can overstate. Even though risk assessment only identifies 60 to 80% of cases that you'll have a postpartum hemorrhage, it helps you be prepared. Next slide. And this is a common tool. It's from the practice bulletin. In most hospitals, I think we certainly do here, do risk assessments on admission to labor and delivery, but don't let it rest with that. The risk change through a patient's labor and delivery and postpartum process. So what we try to do is make sure that we do this risk assessment on admission and then after delivery as well, and in the postpartum period, because it changes. That's just important to understand. So there's both the low risk, medium risk, and high risk categories. And I think everybody knows what they are, but I just put this on here for your information. Next slide. And there's a lot of attention paid to active management of third stage of labor to lead to a lower incidence of postpartum hemorrhage. And that is aggressive Pitocin or oxytocin use, not uterine managed, but uterine massage. And the one that always is a little bit more controversial is umbilical cord traction, because I mean, you just learn how much traction. I'm always asked, how much do you pull on? You just the right amount, okay? Just pull on it the right amount. Gentle traction, careful not to shear the cord, and gentle enough not to cause uterine inversion. Next slide. And we're not going to talk much during this series about abruption and previa, but I think what I'll do is at the very last didactic concerning obstetric hemorrhage, we'll touch on both of these because they certainly deserve some attention. And that is all I have for you today. I'm happy to answer any questions that you might have, or take any other comments and anything that I left out, Donna.